also a very well-known physician, and he's a very talkative and easygoing person. So I think
Okay.
that you enjoy the conversation, okay?
But let not put the expectation so high because uh, no,
So,
Carla,
Actually,
she's
I've
our
seen some of your courses. I think we communicated once after you posted something about point of care ultrasound on LinkedIn. Actually, I did
yeah,
communicate with you. Yeah.
yeah. After we had a talk with Luke Baldwin from Econus.
Yes. 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 Yes.
Yeah. Now, nice.
so I'm going to leave you all
Okay.
alone, okay? Just have a easygoing conversation. Siddiq, then I will tell you when we publish it, okay?
No problem at all. Thank you very much.
Okay.
Have a
This
So,
nice
is
day.
I've just seen your questions. On my job, just going to look at them again. Okay. Thank you. Tell me.
no.
Don't worry.
Siddiq, don't worry. Let's talk like fluently, and this to be a talk like 25 minutes, and it's to be a podcast to be published in our website, and we with our connections, and that's it. I will present me like briefly. I'm a general internist. I'm 47 years old. I have like 22 years of practice, and from these 22 years, from the very beginning, I always tried to do ultrasound, but it was really in the beginning of the this century, the started to read in some papers and more about echocardiography, like the echocardiography was like expanding a lot, and but the point of care ultrasound, I think even it didn't have a name, and then it was like the lung ultrasound of Liechtenstein and so on. But I started with anesthesiologist to putting like catheters with ultrasound in 2005 6, and then we began to teach anatomy in the school where I'm a professor. We started to teach anatomy with the ultrasound, making correlations with son anatomy and so on. But then going to the bedside, it was only like in 2008, 2007 and 8, and starting to do the EFAST. And then I met colleagues from Brazil, and they weren't like looking ahead and working with Italians and Canadians, and starting to make like protocols in the emergency department to better diagnose shock patients and rush and so on. And then it was like really diving in point of care ultrasound, and it's like being a story with 15 or 20 years, but it was in the last 11, 12 years that was really uh, diving in point of care ultrasound. And then it was like the age of the expansion of the ultrasound also. It's my journey, but with the journey of the ultrasound expanding, so because it appeared like the ultra portable ultrasound machines, and then it was that, and I applied protocols in my emergency department. I have a fellowship of 3 months in my emergency department, and then for 3 or 4 years we started to teach ultrasound in the faculty, in the pre-graduate, and to third and fourth year students. And it's that. It's only to introduce myself. And
So, which hospital do you work in Portugal?
yeah, it's in the north of Portugal, and
Porto?
it's in Braga. In Braga,
Braga.
it's
Ah,
northeast from
yeah,
Porto,
yeah, yeah, yeah.
50 kilometers from Porto.
Wow.
And that's it. Siddiq, let's formalize this. We are in a conversation for Pocus Talks podcast with Pocos X Talks, okay? And this is the Pocos Mundi. I began to having talks with colleagues, Pocos enthusiasts from around the world. And this is very thrilling because now we are in the Middle East, and we're talking with Siddiq Anwar from Abu Dhabi Emirate. My knowledge on geography of the Middle East is very basic, but I think it's a state from the part of the how do you
United
call the United Arab Emirates? Yes. Okay.
Yeah.
Sorry for my lack of knowledge of geography.
Cool,
And
cool.
uh, thank you, thank you, Siddiq, and welcome to our talks. I feel very honored to have a chance to exchange ideas from someone. And I saw your brief summary of your curriculum in LinkedIn, and it's very impressive because you are having experience from all around the world. And to start, yes, I talk a bit about me. To start, what I would like, it's to you to present yourself, please, Siddiq.
Right. So, thank you very much, Jose. My name is Siddiq. I'm actually from India originally, from Bangalore. So, immediately after my bachelor's degrees in medicine, I moved to the UK,
Okay.
and I was interested in transplant and interventional nephrology. So, that was my kind of interest. And it's a fascinating story. While I was in Guy's Hospital, London, there was a Portuguese nephrologist who had come to do acute kidney injury research. His name is Dr. Mario Romendo. I don't know if you know him.
Uh-huh.
So, and we were discussing like how things are done, because in part of your journey, your training journey, what happens is you just follow what other people are doing in your track. So in my mind, I was thinking I want to be a transplant intervention nephrologist, and at that time, I thought intervention nephrology is just putting lines, doing biopsies. Then when I
Uh-huh.
was speaking to Mario, he said, in Portugal, we do fistuloplasties, we do PD catheters. So Mario then recommended me to his boss. His name is Dr. Fernando Neves.
Uh-huh.
He's from Hospital de Santa Maria. And then he connected me to Pedro Pons, who was then the medical director of Fresenius. I don't know if he's still there. So I had
Okay.
an opportunity to spend some time in Lisbon, and I did a short fellowship with Fernando Neves, and that got me interested in ultrasound because for fistula assessment you need ultrasound. You need Doppler,
Uh-huh.
and then that got me interested in how to manage fistulas, and then I learned how to do interventions. But still, it was still interventional nephrology, not diagnostic, because at that time, diagnostic nephrology was not a thing. You would just use ultrasound for, as you described, for catheter insertions, for PD catheter insertions, and for fistula assessments. Then I went to America. I retrained there, and I had an opportunity to work with a guy called Steve Bander, who's a famous interventional nephrologist. I did a full fellowship, and again, in my mind, I was still an interventional nephrologist. Diagnostic nephrology was not something which we were thinking much about. So I then moved sometime in Saudi Arabia. They have a very good interventional nephrology service, and then I was hired here primarily as a transplant nephrologist. This was 6 years ago in Abu Dhabi. So, but when I came here, the bigger problem we were trying to solve is acute kidney injury. And just to give you a little background, in hospital acute kidney injury is pretty common. So there was a report from in the NHS in 2012, an NCPOD report. NHS puts out these patient safety reports every year
Uh-huh.
on what are the things which are highest risk of causing death and morbidity in the hospital. And in 2012, the NCPOD report said that 1/5 of all hospitalized patients get in-hospital acute kidney injury. So if you think about in-hospital acute kidney injury, um, it is either too much fluid, too little fluid, or the kidneys are blocked. And for that, legacy way of doing things is um, you do an X-ray, you do lab tests, you do a departmental ultrasound, and then you do an echocardiogram. Of course, that's a snapshot. And in the patient hospital journey, The patient could one day be fluid overloaded, one day could be hypovolemic, and of course, in perioperative scenarios, patients who are constipated on certain medication, they get go into retention. So, as I was optimizing the end-stage renal program in Seha, I realized the money which is being spent to look after renal disease is unmanageable. And when you're working in NHS, you don't think about money, but when you come to systems where there is a payment for activity, then you just start thinking. When I was looking at the numbers, this is unmanageable. Just to give you some numbers to mull over, 10% of Medicare budget is spent on dialysis. That is
Uh-huh.
close to 60, 70 billion. 25% of Medicare budget is spent on complications of kidney disease. Because as you know, kidney disease patients are at high risk of developing heart failure, strokes, MIs, and they are recurrent hospitalization. And I did a small study when I first joined here. Dialysis patients are actually high risk of hospitalization as well. And if you think about dialysis patients, why are they getting hospitalized? Largely it's fluid overload. And you see that Monday, Tuesday morning, your emergency department is filled with dialysis patients who are fluid overload. And that is ESRD population. And acute kidney injury, as we can see from the NHS report, 1/5 of all hospitalized patients get AKI. So in hospital, AKI is a patient safety thermometer. And usually people who get AKI are septic patients, perioperative patients, trauma patients, burns patients. I mean, you name the scenario, hepatorenal syndrome patients, cardiorenal syndrome patients, and these are recurrent customers. And the tools we use to assess volume status in internal medicine subspecialties is still stethoscope, an instrument of 19th century, and it should have stayed there. And the costs are humongous to manage, And if I'm thinking about the like a global picture, just to give you some numbers, I'm from India. 200,000 people end up on dialysis annually. 10% of the world's population has CKD, and these are volumes of patients which the current model cannot deliver high quality care. And I think so. Ultrasound will be a game changer, not just for volume assessment of the kidneys, assessment of fistulas, allowing physicians to put catheters, indwelling catheters if patient needs dialysis. So that's how I came to ultrasound as a diagnostic modality. Of course, I need the ultrasound as usage as an interventional tool. So while I was thinking about this, then I got to know two pioneering nephrologists who I have to credit, who are kind of even though they're younger than me, who are my mentors and my trainers. One is Abhilash Koratala
Oh
from,
yeah. And
and
did
then
you met
Edward
him?
Varghese from Mexico. I mean, these are nephrologists who have taken diagnostic nephrology to a complete different level, and they have been very helpful and supportive to the program. So that's like a brief story of how I ended up into point of care for diagnostic purposes. But there are other things which I'm talking about. But this is how I reached to this kind of conclusion that the point of care should be part of your daily assessment for volume status in the
Yeah,
hospital.
Siddiq, that's an amazing background. I'm like flabbergasted, and I totally agree with you because as the physical examination is so enthroned in our common knowledge we have from the faculty, and we never question the physical exam. And when you do ultrasound at the bedside, you see how many times do you fail, and the volume status is one of the big topics on the failure of the physical examination. And
Yeah.
then we rely on the complementary exams, and then they are, like you said, a snapshot. And one of the things I try to wrap all the things you said is it's to stopping to talk about the volume statums and say like the fluid responsiveness. We have to talk about more about the volume status and the The question is if the patient will be tolerant, and is the fluid tolerance. And this is a change that is not only about words, okay, and it's about the being more dynamic and with a more deep knowledge about the physiology and the hemodynamics. And I think it's because you said you changed, or you began with diagnostics, and then you apply the ultrasound in fistulas and so on, and evaluate on the acute kidney injury, because it's really dynamic. You have to reassess the patients more times, and you have to integrate knowledge that the ultrasound, it's I think it's the best way to integrate the information at the bedside and immediately, and in a sense that you can test your hypothesis, because you are giving like fluids, and then 10 minutes after you are reassessing again easily, without being with a huge effort, and with the portable machines being able to repeat the exam times as times you want. um, are you catching what I'm trying to
Yeah,
say?
yes, of course. I mean, I completely agree. And I think if you think about the way we were taught, it's still the same principles since late 1900s, early
Yeah,
1900s. I mean, inspection, palpation, percussion, and auscultation. And I mean, my clinical skills are deteriorating. I know that. And I can't hear as well as murmurs I used to. Um, I mean, I think the installation should be standard of care. I mean, there was an excuse the cart-based machines were so big that it can't be done around. I can share you some pictures. I've mounted these machines on a small stand,
yeah,
and they're easy to be. You can take them along on your rounds. And some of these machines have color, Doppler, tissue Doppler. So I mean, the quality of examination which can be done at bedside, answering a simple question for me as a nephrologist: do I need to give fluid, or do I need to give diuretics, or are the kidneys obstructed? I mean, this is what I am thinking
yeah.
in hospital acute kidney injury.
Siddiq,
We are
in
not
my
diagnosing vasculitis on the floor when patient who's been in the hospital for 3-4 days. I'm largely dealing with volume status or obstruction.
and the safety of the exam. I did an experiment in my hospital with a cohort of 53 patients, and we assessed the patient with acute kidney injury, and the question was, does he have the urinary tract obstructed or not, and to see if there is hydronephrosis or not, and then to orient the patient. The doctor that was orienting the patient didn't know about the exam of POCUS, and he ordered the exam in the regular form, or radiology departmental exam with tomography or ultrasonography, depending on the availability at the time. And then the POCUS exams, we did the POCUS exam in a 3 hours frame in the same examination. And we had like 11 patients with hydronephrosis with the POCUS teams, and 11 patients in the departmental imaging with obstruction. Those 11 patients from each group only diverged in one patient that POCUS said that it was hydronephrosis, and the imagologist say it was not, and the opposite. It was like the result, a sensitivity of 91% and a specificity of 99%. And this was made with junior doctors, okay? They only had 8 hours hands-on training on doing ultrasound. Then I reviewed the images, and the one they said that it was hydronephrosis, I said it was really doubtful. And this is like a very light uh, uh, aspect that probably if we reassess the patient half an hour later, or after pouring the bladder catheter or so,
Yeah.
something else,
So,
and
I think the critical.
it's very safe. In my hospital, these patients that are awaiting the imaging to see if there is obstruction or not, sometimes they wait 12 hours because it's the end of the shift, or they do a tomography, and only the tomography is only to see if there is obstruction or not. And then we postpone the treatments, and we postpone the orientation, and we postpone the admission to the wards. All these aspects are to be seen as like efficiency, and then the efficiency has the problem of the safety, because if we fail to see an obstruction, or we say that is an obstruction, is not, it's a problem that it can get the patient in troubles, because it can postpone some other exams, or not. But this is safe, and our cohort was validated with another cohort that we saw in the UK, that they did the same study, very similar, and with the same numbers. We have to publish more on that, more on these aspects of feasibility, and then comparing with the gold standards and with the physical exam, and not only to convince other colleagues to start to do ultrasound, but to put efficiently in our systems, and to measure really the impact, because the impact in ultrasound, in point of care ultrasound, can't only be measured with the hard outcomes like mortality, because it's not a treatment. The treatment in pulmonary embolism is like if he's doing thrombolysis or not, or if he started in a time frame, right time frame, the hypocoagulation or not. It's not the ultrasound that will treat the pulmonary embolism. It's the same in a urinary obstruction. And if we measure the groups, probably we won't see difference between doing like we are doing and ultrasound. But if we measure the efficiency of the system, the empowerment of the one doctor that is like correctly doing the things and earning money to the hospital, tying to the patient, and less suffering, these are soft outcomes that are not regularly measured in studies. We have to be more assertive on these aspects, and we as educators, and me in my university, I think you teach also in Abu Dhabi, and then this very enthusiasmating. I ask you, because I'm talking about training and so on. What are your vision in Abu Dhabi, and some of the key objectives or goals of focus training in Abu Dhabi? Are you working in some project, or trying to put things in broader healthcare in your region, or?
So I think so. Just to kind of go back to your last statement, point of care is this is focus is point of care, and it is not going to delay treatment. And if this tool is not available for the doctor, he will do something. He or she will do something. Now there is no guarantee that the clinical examination without ultrasound was actually accurate. So I think so. The burden should not be on the point of care ultrasound making an outcome difference. Is just we're just adding extra information to the doctor. So in the end, the information is going to be analyzed by the physician to make the right judgment. So I think so that I completely agree with you actually. So the objective. So I think the three challenges we had to overcome. One is, why does internal medicine doctors need to do point of care? I think that's the biggest challenge, because right now it's not an ACGME requirement or a Royal College physician requirement for internal medicine subspecialties. Now for ED and and ICU, they embrace point of care ultrasound 20, maybe 15, 20 years ago. There it is part of the curriculum in ACGME and for Royal College of Physicians. But the internal medicine specialties have not embraced this wholly. Cardiologists, of course, have advanced echo skills, so they already do that. But other subspecialties, it is not part of that. I mean, we just had a revision of the curriculum for American Society of Nephrology. They're not even insisting interventional procedures being done. So largely because I feel the people who do the education curriculum are not practicing clinician. I don't want to be like I just I'm not being unnecessarily provocative, because they've forgotten what's happening. The reason is, in healthcare, learning new skills, micro learning, and learning and learning has never been embraced. So what used to be taught is, I become, let's say, a transplant nephrologist. I remain a transplant nephrologist. I become an expert on this. I keep doing the same thing again and again: patient safety, streamlined processes, and either I retire or die, doing just learning that one skill. But I feel, as you describe, we need to show that short courses will allow an established practitioner like me, or someone even my senior to me, or even like someone who's younger than me, to learn a skill. Because historically, what used to happen was, you go through a training program, medical school, and then your residency and fellowship. And after that, the CME, the continuous medical education, is just to kind of maintain you at that level. Now we have to acquire we have to get the new people onboarded in point of care ultrasound. So that's one thing which I have been advocating for the last 5 years, and I'll talk about what I've done. The second challenge is, can we teach them in short courses? Normally it's a badge of honor for the sonographers, cardiologists, radiologists, that they learn this skill for 5 to 10 years, how to acquire images. And hence the training program has been long. So when we are saying that, oh, I can teach a internist to assess volume status and rule out obstruction with a short course, we have to overcome this mental barrier. And we have published a study. It's been accepted, it's in print, and this was just exactly addressing that point, that we can teach people in a short course to acquire enough skills to answer bedside yes or no question. Should I give fluid? Should I give diuretics? Or the kidney is obstructed? And the third level, of course, is a pathway for credentialing and licensing in the hospital. So I don't know how it works works in Portugal. One is credentialing. That means you can acquire the skill, and your peers can endorse you in the hospital. One is licensure, which allows you to do billing. So here we have to get the regulators on board, and unfortunately, the regulators will only agree if the Royal College and ACME and other education bodies embrace. So I've been tackling this challenge in three ways. A, to create awareness that the internal medicine specialty, adding insonation as a fifth pillar of physical examination, will improve patient safety, reduce cost of care, allow point of care assessment, and early efficient care. Second is, we can train people in short courses, and we're going to publish, you'll see a paper come out shortly. It's accepted, and we're just going through the final revisions. And third thing is engaging the senior stakeholders to allow credentialing pathway, at least for someone who's my stage of career, who wants to acquire a point of care skills after doing a short course and doing the number of images which the Society of Hospital Medicine says. And then you get at least credential in the hospital. And then, of course, in the interim, also engage the regulator so that they can allow point of care ultrasound to be acquired as a additional sub-certification. Like, I'm an interventional nephrologist, they can apply as a diagnostic nephrologist, or as a point of care certified physician. So that I know there's already some programs in America where they have a focused fellowship for medicine, not for ED or ICU, I'm talking focused medical fellowship, but that also needs to be established in this region. And third thing is, of course, we need, so fourth thing is to create a pool of educators who can do the training and who can do the QA, so that we can get a robust program. So it's not like Jose and Sid's, a toy which they are playing around in the hospital. The example I give is, unless we diffuse these best practices from ED and ICU into internal medicine, whatever assessment ED and ICU make is not something internal medicine doctors will follow. We'll end up requesting chest X-ray, echo, and it spoils the whole picture. And next day I come, I'll do the same thing again. A good example would be when everyone in the hospital could start reading ECG. A nurse, a paramedic, a nephrologist, a gastroenterologist. You could build BLS, you could build ACLS. Because everyone in the hospital knows shock, shockable rhythm, non-shockable rhythm. Everyone in the hospital knows shortness of breath, hemothorax, pulmonary embolism, so how the algorithm works. But the fundamental basis is everyone could read ECG. So we should reach a stage where once my internal medicine resident calls the ICU doctor, says the VTI is this, and this is this kind of shock, automatically the ICU doctors say, okay, this needs to come for presses. So the two scenarios I'm working on in the hospital right now: undifferentiated shock, undifferentiated shortness of breath. I'm keeping myself narrow focus to this, so I don't get into the radar of radiology and or cardiology spheres. Undifferentiated shock, undifferentiated shortness of breath, and this is in bread and butter internal medicine. This is what we do every day on the rounds, and for that we do battery of tests. This is pointless. Point of care ultrasound will eliminate those steps. So those are the things I'm working on right now.
No, Siddiq, so great, because narrowing the focus is the best approach to do scientific research. If we do like 10 questions at the same time, we won't answer any of those questions. And this is like the research part. And I began also like making the difference in obstructing hydronephrosis. The doctors in my hospital, even there is informally, but now they trust in our team. We have like a focus team in our emergency department, and when we are present, they rely on our exam if the doctor doesn't know how to do it. And then we have another program that is like I'm doing observational and not intervention, only observational, that is like comparing the notion that the doctor has for congestion, if he doubts if the patient is congested or not, and what is he doing, and then comparing with a POCUS assessment. And we are controlling like all the information not to be influenced by the doctor that is doing POCUS, and to show that, and we have like now a group of 70, 80 patients, and those patients that were both classified as minor congested or severely congested clinically, we change a significantly group of those patients doing ultrasound and with a basic echocardiography, and then seeing if a score of Vexus, not the total score, sometimes only the portal vein and so on. And then this is the kind of thing we are trying to do in focus research. In a bigger plan, we have a study group inside the Portuguese Society of Internal Medicine, and we are starting as in Spain they started a bit earlier, and we are like gathering experts in point of care ultrasound in Portugal with some invitation from abroad. And I'm talking now to you, probably I don't know if you will be like asking and we are like narrowing a list of possible competence in internal medicine for point of care ultrasound in internal medicine, and choosing in a Delphi format, and then we'll try to publish that at the end of this year, and to help to design the programs that I think at the third level then they should be designed specifically to an hospital. It's different. I work in a big hospital with all the specialities, and we have like a big intensive care department with a big nephrology department. It's different if you are working in a small hospital with a small ICU unit and without the gastroenterology, for example, or other specialties. Okay, and and we have to think how to design the best programs. And I'm very thrilled to wait for your paper, because in Pocos X we are like very fond to do short courses, but with a very uh, very close approximation with the student. And this is micro learning is very important,
Yeah.
because it's not to be disruptive with the doctor knows, is to be like adapting with what he already knows, and to potentiate that, and to put like in a best path of reasoning and in efficiency. And it's for that that the micro learning works. Okay, and it's not too complicate like some colleagues like from imageology, for example, that they think that we are like teaching um, second degree imagery. No, this is different from a perspective of an imageologist. Okay, it's like using ultrasound physics to help us to better think and to better decide what the patient needs. And this is because that the microlearning works, because
Yeah.
the student knows a lot. He only
Yeah.
needs like to integrate some information
Yeah.
that now with the portable machines, it's easy to get this information at the bedside. And it's like the revolution that was made in blood analysis. We have machines that we can measure the glucose at the bedside. If you
Yeah.
think on that, it was like technology that took tens of years, right, to miniaturize and to calibrate, and then you trust on that, and you are
Yeah.
thinking better, because you don't need to wait if the guy has hypoglycemia or not.
Yeah.
And it's the same with imaging. Now we have like the imaging like touching the body of the, and I see if the heart is squeezing or not, or the vena cava is totally collapsed, or if the flux in the portal vein is like pumping or is continuous. Okay, and see, this is very very enthusiasmating. We are waiting for an article, and I'm really like want to work with you in the near future. Okay, because
Definitely. I mean, I
we
think
are
one of the things which,
like
yeah.
40 minutes. We have to
Oh,
thank our listeners. Okay,
okay.
but we have to end our conversation. It was so great. You put the topic so clearly, and those levels of advanced, intermediate, and going to the narrowing, and then going again to see the big picture. It's very 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 nice. Thank
Thank you.
you, Siddiq.
Thank you very
And
much.
tell us when your paper is out. Okay.
Yeah, I'll let you know. And actually, I work very closely with a group from Argentina. I don't know if you know them,
Yeah,
Francisco
as a rook,
Azaro.
as
Yeah.
yeah,
So
man.
the big challenge for us is UAE. Just to give you some demographics, we are a population of 9 to 10 million, and only 1 million of them are Emiratis. So most
Okay,
of the healthcare delivery is done by expatriates, people like me. I'm not Emirati, and
okay,
so maybe 99% of the workforce is non-Emirati, which has meant that they are dependent on expatriates for knowledge
okay,
transfer and capacity building. And many of these projects, as you know, Jose, I don't know how long you've been doing this space, they take 5 to 10 years to bear fruit. And most people come here for a short time. And that has been
okay,
my challenge, because to get like what you're telling me is you've already got the intermission society to engage with you. You have a bunch of colleagues all advocating for that. So one of the reasons I had to collaborate from outside is it- because I need people to come and help me support the training programs.
Okay.
And hence, Eduardo has come, Abhilash has come, given me a grand round. This Hatim Soleiman from Royal Brompton. So he came from Egypt, but he trained here, and then he went to Royal Brompton. So all these guys have been supportive, and for the listeners out there who are starting their point of care journey, there are of course great online resources being put out by Abhilash, Eduardo, folks like yourselves, but there are people out there to support you as well, and when I was struggling to get people to come, I mean, these people came, to support me. They given me their time, um, and I would. This is what I recommend. So, it's very one of the guys I trained. He's now started his own program in a parallel hospital, and
Okay.
that is quite, like, okay, this is legacy building. So what I would suggest to folks who are listening, who are starting their journey, is you can reach out to people like you, me, because all of us who are doing this, we are doing this because we feel this is the way to go in the future. The current system needs to be disrupted, and you will find folks around who will be willing to support. Yeah,
Oh
thank you very
man,
much.
what a great message, Siddiq.
Yeah,
Thank you. And
thank you.
let's talk very in the very near future. And
Yeah,
let's go to Abu Dhabi, man. And you,
definitely. It's a beautiful part of the world.
yeah, man. And
And
we are waiting for you here in the north of Portugal, because Portugal is not only Lisbon, okay? Some of
definitely, I
our
will look up.
listeners will be pissed off because, okay, man, it's the guy from north of Portugal. But okay, thank you,
Thank you very much.
Siddiq, man, and thank you so much. Okay,
Thank you very much.
and
Okay.
to our listeners, thank you for listening us, because if you are listening now, is because you heard of all the things we said that what very very important. It's our experience, our patience, and this works, okay, man. And see you in the next post Pocus X talks. Okay,
Thank you.
thank
Bye bye,
you.
guys. Thank you. Bye bye.